All right, you're taping.
Okay.
Good.
Can you first start by telling us where and when you went to medical school?
I graduated from Harvard Medical School in 1954.
And then what did you do afterwards?
The first 2 years after medical school, I was at the Boston City Hospital doing internal medicine, a straight medical internship, and then first year medical residency. They called it internship then, not PG1 as you guys do now. Then you're probably familiar with the fact that there was a draft doctor's law back in those days, and so I had been drafted actually to go in the service after the first year of training, but try to postpone it because I was to get married to my still wife of 45 years, and postponed going in until after my second year of medicine, which was good because I got a very good job through that. We were then drafted into the Army. It was a law that probably wouldn't pass now because it was discriminating against physicians. The only people that were drafted at that time were doctors. This was sort of between the Korean and the Vietnamese War. In the service, we first went down to Texas for a couple of, well, about 6 weeks, and then I was asked for overseas duty, hopefully that I would not get sent to Korea because I had a wife and a 6-month-old son at that time, and luckily was stationed at a very large general hospital in Germany. So we lived in Germany for 2 years, and it was excellent, not only because of its location, so we could travel around Europe a great deal, but we had, there were 4 general hospitals in Europe at that time, considering that there was going to be a war with Russia. They had all the general hospitals over on the very western side of Germany, almost in France. We could throw a rock into France. I was at the 98th General Hospital, which was the general hospitals all had its own subspecialties, and ours was chest diseases and infectious diseases, and most of the patients that were sent in there were patients that had been at one of the other field hospitals or other hospitals and needed the expertise of our institution. All the general hospitals were, at that time, 2,000-bed hospitals. 1,000 beds was on the first floor. They were sprawling institutions, and they were pretty full. And 1,000 beds was on the second floor. In case of a war starting, they were all made up and ready to go. But we used the first floor, 1,000 beds. And it was good training. We had our wards, and I was able to do internal medicine and had German interns and residents, so we had rounds, just very similar to what goes on here now, or what was going on in our training programs at that time. So it was good because we had access to good medical care and medical teaching, and we could do our own teaching, and it was interesting in that respect, but it was also interesting because we could travel a great deal and saw everything and anything in Europe. You name it, we were there twice. And because we were out in the hinterlands, which was in the Schwarzwald, that's the Black Forest, we were given extra leave. So practically every month we took at least a week off, and we could drive anywhere. Zurich was 6 hours away. Paris was 3.5 hours away. So it was very nice. Luxembourg City was for an ice cream cone after dinner, and it was good duty. After the 2 years there, I returned to Boston, and I took a year of my third year of internal medicine then with Maurice Strauss at the Boston VA hospital, and then I was luckily accepted by Franz Engelfinger to do my gastroenterology training. And this is for the archives, so everybody in the archives will know who Franz Engelfinger is, but for your purposes, he was probably the best person to train in gastroenterology in those days, and eventually became the editor of the New England Journal. And after my gastroenterology training, he offered me an academic position either in San Francisco or Atlanta, Georgia. And I turned them both down because we were New Englanders and we had tasted being away from family, both of our families being here in New England. By being in Germany for 2 years, we didn't like the idea of being away from family, so we opted to come to Worcester. There were only, at that time, only one other trained gastroenterologist in the community. Now I think there are about 40, but so that's a major change of how things have gone on in the years since we started, which was 1960. Anyway, that's pretty much the background of my training and how I got here. And after a few years of being here, well, let me go back. When I spoke with Franz Engelfinger about not taking either one of his jobs, which, just for your interest to show you the contrasts from those years to now, both jobs were offering a salary of $25,000 a year, which my wife and I thought was just absolutely the greatest income we could ever have. That was magnificent income back in those days. Of course, now it's quite different, but I spoke with Franz Engelfinger about our not taking the jobs, and he said, well, if you go out into a community hospital or a community that hasn't got academic gastroenterology, it's you have to make your decision within 3 years. Either come back and I'll get you another job, or it's going to be too late because you really, the decline in your being informed and keeping up with the literature and staying with an academic program is downhill if you're not in an academic setting. So in any event, I came here and I spent the first year at the Worcester City Hospital, which was my primary hospital, and decided that the best thing for me to do to get to know the community and to get to know who's who in the community was to take the job as the chief resident, which is an extra year of training for me, but also worked in the division of medical education there. And we had a grand time of, this was the end of getting all-American interns in our house offices at the Worcester City Hospital. So we had a good program, and I enjoyed it. And then at least I did get to know who was who in the community, and started practice the following year. And those were the days when you could just put a shingle out in front of a door and be accepted to the staff of various hospitals. And I was on the staff of the city, Hahnemann and Fairlawn. Both Hahnemann and Fairlawn are no longer functioning as inpatient hospitals, as you well know. So things got going fairly rapidly, and within a couple of years I was as busy as I wanted to be. And then you could really do primary care medicine initially, and then could make it so that you did mostly gastroenterology, but if patients then asked you to stay on as their primary care doc, you did, because that was just the way things went in those days, and it was good. I mean, patients preferred to have the doctor that they saw if they liked him or her. There weren't many hers then, but they enjoyed having them as their primary care doc. In any event, what did happen then? Oh yes, in 1964, remember I told you that Franz Engelfinger said don't stay too far away from academic medicine or academic gastroenterology. In 1964, I was getting very frustrated with the lack of academia in Worcester, and I had my 10th reunion from Harvard Medical School. Remember, I got out in '54, so I went down there. I had been moaning and groaning to my wife about how we really should go back to Franz and get an academic job in gastroenterology, and went down to Harvard Medical School, and we sat around the quadrangle and talked with my colleagues my classmates, who were now the professor of this or written a textbook of that or doing research in something else. And I found out how many problems they were having and came home and I said to my wife, don't let me ever groan and moan about Worcester anymore. We're staying right here. And that was also the decision was made not only because of the problems of getting into academic medicine or being in academic medicine, which I heard from my classmates, but the legislature at that time had decided that Worcester was going to be the place for the new medical school, where we're all sitting now and where growth is still going on. But so I had decided that, well, I'll wait it out and try to get in on the ground floor, which I did. And as soon as the school started, which was down at the Shaw Building, which is the building on the corner of Belmont and Lake Avenue, that rounded fronted building, got involved right from the very outset. And then I was on a committee to appoint the chief of gastroenterology, and we interviewed quite a number of people. And Greg Eastwood was our first chief of gastroenterology. At that time, he had asked me to come on full-time as in gastroenterology, but the hospital at that time only had 75 beds, and it didn't have a full group of subspecialists, so that referrals were difficult. So I said, well, no, I would want to keep my private practice. And I said, when the hospital gets a little larger and there's more of a group of subspecialists around, I'd be interested. In the following year, it had gone up to, I think, 125 beds, and was re-asked and came on. So that's how I got here, and have been here ever since. I don't know if you want me to just go on, or you want to ask specific questions.
I was interested in what had prompted you to come out to Worcester from Boston, and what differences did you find in Worcester?
Well, of course, I can't really tell you what practice was like in Boston, because I was in training hospitals, the big training hospitals that you're familiar with. They're still there. The city no longer is called the city. It was, when I started there, it was a 2,000-bed hospital. It was full. I mean, they had a whole building for medicine, a whole building for surgery, another one for OB/GYN, a whole building for pathology, and so forth. It was a huge, huge complex. It's now part of the BU system. It's the Boston Medical Center. And I think it's down to about 600 beds. So then at the VA, of course, it was a very large hospital of about 800 beds, always filled. That was still in the day when there were a lot of veterans that were still alive and were using the facilities of veteran institutions, and we had a marvelous training program there. So really, it's hard to compare what Boston practice was like. Boston, to me, was a place to go to medical school, a place to do my training in, and to rub shoulders with a lot of, famous names and lots of good house staff. And I think, obviously, you learn most from your fellow house staffs, no matter where you are and whenever you train. But you also learn a great deal from the people that are the full-time staff people. So coming to Worcester was different in that the city hospital where I was first, where I first was, took a year of training and then stayed for a bit, it was fine. It didn't have very many full-time people. As a matter of fact, there were no full-time people. Eventually there were a few. So it was mostly practitioners that had offices outside of the institution, and they brought their patients in. So that was the major difference. I got a feel for what the physicians were like, what they practiced like, and I must say that having gone to Harvard Medical School, one of the things that unfortunately sort of pounded in your head is that, this is the best institution in the world, and, you're this is, everybody from Harvard is a great doctor. Well, I came to Worcester, and after about 3 months, I came home to my wife, and I said, you know, there are an awful lot of good doctors around here, and most of them did not go to Harvard Medical School. And so it's, that was a very interesting learning experience.
Was Worcester a very different city then than it is now?
Yes, it was. Downtown Worcester was vibrant. It had quite a number of department stores. It was busy. The community itself was growing. It had a growth spirit of developing housing, and in around 1963 we had purchased a home in right near neighborly Newton, as it was called, on Coolidge Road. And we built a home way out near the Holden line off Salisbury Street. And our only concern was that we were out in the woods and that was too far away from town. But of course, it's now completely grown up and there's hardly a lot of land available. So it was quite a different community, and our children all went through the public school system. It was a good community to get involved with. In 1967, was asked to, I had been involved with school activities because our children were all in the schools, and was asked by an organization called the CEA, or the Citizens for Planning Association, to run for the Worcester School Committee, which at that time was an at-large political position, and ran and was elected the first time, which was difficult, but it was a good experience, and first of all in public speaking and learning how to get up in front of a crowd and talk, and secondly how to serve a large community. And we on the school committee were fiscally autonomous at that time, so we could spend what we wanted as long as the community didn't get up in arms and get concerned about how much was being spent for schools. But it was very school-oriented, and our kids all went through the public schools and all went on through very good schools and graduate programs.
Do you think that your role as a physician impacted how you went about serving the community?
Well, I think I was a little bit of an anomaly in the sense that I wasn't the joiner of all the medical societies, although I was a member of them. I wasn't fully active in them. I was more active in the way I just outlined, in joining community activities outside of the medical community. I felt that I had enough medical connections and contact within the hospitals and socially, and felt that we should be giving to the community at large. And so that's how we got involved with being on the school committee. And then subsequently, when we were in different communities, we've been involved, we, meaning my wife and I, have been involved in different ways. We're now living in Northborough and doing several things on several major committees there.
Do you think it's unusual for physicians to be involved in that way, though?
Yes, I think that a few physicians did try to run for the school committee and were unsuccessful. Most of the physicians seem to be more involved with the medical societies and the medical aspect of things, which is fine. That's their choice, and my choice was to go outside of the medical community. And I really feel that if people that are supposedly well-educated and don't give of themselves to the community at large, then we're bequeathing to others the responsibility of running the communities. And So we have more to give than just to care for patients. And it's worked out very well. I've enjoyed my community responsibilities immensely. It's been one of the more broadening aspects of my life.
What do you feel are some of the biggest advances you've seen in medicine, especially in your field since you started practice?
Oh my goodness. When I was training in gastroenterology, Franz Ingelfinger had never passed a gastroscope. At that time, the gastroscope was called the Cameron Flexible Gastroscope, and only the distal, I think it was 6 inches, had any flexibility at all. Otherwise, it was sword swallowing. And the view was only a 60-degree view through a prismatic lighted end. So you could swing it around and see some of the stomach. You could never get into the duodenum, of course, and it was too close to the esophagus to really visualize the esophagus. So that really was an ineffective tool, and we did not do very many of those. Let me stick to endoscopy first, and then we'll get to some other things. Of course, people knew about fiber optics back in those days, but they weren't perfected, and fiber optics then came to the fore in the 70s, and the first flexible fiber optic scope we got, and we had to learn ourselves how to use it. There were courses given, and we took the courses, but you know, the course doesn't teach you how to manipulate the scope, and so it was really learning, on-the-job learning. And of course now, not only are there magnificent scopes, but you don't even look through an eyepiece any longer. You manipulate the scope, and they're getting smaller and smaller, and the views are just beautiful, and you see them up on TV screens, and you can pass all sorts of wires and tubes down and get biopsies and take out polyps and do stop bleeding and do many of the things that we're familiar with. So that endoscopy has certainly changed the whole panorama of gastroenterology. The other thing that we did when we were in training, we used to use what was called a Vim-Silverman liver biopsy needle, which was an archaic piece of equipment that you took a slice of liver out, which was probably in the vicinity of 8 to 10 centimeters long, because it was squeezed by the needle. It wasn't that difficult to use once one learned how to use it. But now, of course, the Mangini needle and suction biopsies and repeated biopsies and biopsies with the assistance of the CT scan and are not only easy but precise, and it's really out of the hands of the gastroenterologist now. It's to hit a specific lesion is really in the hands of the super radiologist specialists. And so there are, and then of course the whole concept of what caused ulcers and has changed our whole way of treating and managing the inflammatory bowel disease or irritable bowel syndrome. All has changed drastically. So really, I must say that there's practically nothing that we learned in. Well, you'll find this out as for the audience who's watching this through the view. I'm speaking to first-year medical students, and you'll find out that probably very little that you learn in medical school will be used 15 years down the line. But things change drastically. I mean, here we are in the day of the genome, and genetics was hardly even known in those days. We all thought there were 28 chromosomes back in those days, and let alone the autoimmune disorders and immunology being as it is. So all of these entities are things that we had to learn as we went along. And reading the literature, you'd go back and try to get a book on immunology or genetics and try to learn what's now taught in the first year of medical school.
Do you feel with all the advanced diagnostic techniques and new technology that physicians view their role more as they have to be able to cure something to be successful, otherwise they're not satisfied? Have you seen that throughout your career?
No, I think there was always a feeling that our role in life was to heal the patient, but to do no harm. There was much more personal attention to the patient back in those days, but nobody was telling us how much time we could spend with patients. And in my practice, I always had an hour for each new patient and never scheduled more than 3 follow-up visits per hour. And that way we could stay on time, and patients weren't fuming because they were waiting in a waiting room because some third-party insurer was saying you have to see 6 patients an hour or every new patient in 20 minutes or whatever. So no, I think that I think the practice of medicine was in some ways much better back in the days that we weren't so technically oriented. The technical orientation that we have today forces us to think CT or MRI before we think of that there is under the stethoscope a patient, or a heart under the scalpel there is a patient. And so I think that that's somewhat being lost, and that's not because the people that are going into medicine are jaded or any less interested in the care of people. I think that they're being told what to do by the HMOs, the third-party payers. There's much more paperwork that has to be done today. There's much more of a rush to jump right into what one might think technically will give a final diagnosis, so there's more of let's get an MRI immediately, or let's do a CT scan, depending upon what you're looking for. And you don't get just the blood glucose anymore. You get a Chem 20, and it's a cheaper way of doing it. And so the whole spirit of the practice of medicine somewhat has changed. My involvement for the last 5 years here at the medical school has been through the PPS course. I've been involved with both PPS 1 and 2, teaching both for the last 5 years, and enjoyed it immensely. And I think it's a marvelous course because it does give the students a feel for the doctor-patient relationship. It gives them a feel for the ethical aspects of the practice of medicine. And I think our students are ahead of many of the other students because of the course, the PPS course. But anyway, I don't know if that answers your question or not.
Can you talk about when did managed care start impacting your practice, and a little bit more about what it has done to the practice of medicine?
Well, in the early 60s, Blue Cross and Blue Shield started to come in, and that was the first health care insurance. And they limited the number of days a patient could stay in the hospital and the amount that you could charge for your fee. But that was the first impact, and I remember doctors sitting around the dining room table at lunch at the city hospital talking about how this is going to wreck medicine, and it's going to have our income is going to be drastically reduced. And of course, it wasn't that way at all. If anything, it increased the income of physicians, and it was unfortunately abused by a number of physicians, and they would hospitalize practically everything that crossed the threshold and use up the Blue Cross and Blue Shield and then discharge the patient. Inpatient care at that time was good. There were plenty of good nurses. It was inexpensive. I can't recall the exact per diem costs at that time, but I think it was something in the vicinity of $25 to $30, whereas today it's what, $600 to $700 or more. So that was the first Blue Cross and Blue Shield. Was the first third-party insurer, and then almost everybody did have Blue Cross and Blue Shield. It gave them the security of knowing that if they ever did have a serious medical illness, they would be able to be hospitalized without becoming, financially burdened. Subsequently, I recall all the other things that, Medicare started, and everybody was sitting around again, worrying that this was going to destroy their income and destroy their way to practice, but it really did not. It just gave the elderly a better chance to feel that they could reach medical care. Medicaid did the same thing, and then the thing that really started to become what I think was rather destructive, or has become destructive over the years, is the other HMOs, the health maintenance organizations, which are just everywhere. And there are so many of them that many doctors that are now in private practice or in group private practice have to hire a special person just to do the bookwork of filling out the forms for the different HMOs that they're a member of. And you're not limited to just be a member of one HMO. You can join the Tufts, the Harvard, the BU, all of the programs. And they all have different forms. It would be nice if they did what students can do now out of high school. They fill out just one application for college, and that one form is all they have to fill out. Well, that would be nice with the HMO. Just fill out one form and just put the name of the HMO on the top. But that has, I think, been the destructive element. It's only occurred significantly over the last, I should say, 15 years. But that's a long time, and I think there's been an uprising on the part of not only the physician population, but the patient population, and now the legislature passing the Massachusetts legislature just recently passed the healthcare bill, which is going to, I think, help reduce some of this difficulty. But this has to be done nationally. It can't be done state by state or region by region.
Do you feel quality of care has suffered in the last 15 years?
Yes, I think it has. I don't think that, I think diagnoses have been more specific, that management has been more specific and probably more direct and better. But patient care has suffered because the doctors are now told how many patients they must see. They haven't got enough time to do the hand-holding and and be able to spend time talking with the patients that they used to be able to do. It wasn't easy to do it always, but it was done. I don't know, I've been out of practice now for a long time, but I used to always make certain that if a patient of mine died, I went to the home, or I went to the wake, or to the funeral, or to the Shiva, where whatever it was, that whatever religion the person came from. And patients appreciated that. I'm not so sure that the young docs are doing that any longer, but it's not because they're any less concerned about their patients or their families, or the patients' families, but they just don't have the time to do it.
Do you feel physicians are somewhat responsible for the way the policies are set? Like they should have been more involved in the beginning for policy making?
Well, that's very, very difficult to answer. The hindsight is cheap, and it's certainly, by virtue of what's happened, the answer to that is yes, they should have been more involved. But it happened so gradually, and it just sort of snuck up on people so gradually, as I mentioned a while back, that Blue Cross and Blue Shield was there, and then Medicare started, MedX, and it really didn't bother the practice of medicine significantly. But then when all these different other agencies came in, and they just sort of drowned people with paperwork and with responsibilities that were not really directed toward the management of the patient, then I think physicians did become involved. So they got involved at the time that they really felt that they were being, that their practice was being changed by virtue of the outside influences. So sure, hindsight, I would say it would be nice to be able to predict what was going to happen, but there was nobody that was able to really predict it.
Over the years, how do patients without money get health care? Has that changed?
Well, I can't speak for everybody, but I can speak for me and for my own colleagues. If nobody was refused to come into my office, if they were referred by another physician, and eventually I'd had an all-referral gastroenterology practice, we just saw them. If they could pay, they could pay. If they couldn't pay, well, we wrote it off. So, but then again, don't forget, we had in private practice, we were allowed to do what we wanted. I was lucky enough to, when I first came to the medical center, I stuck by my guns and said I wanted to continue to, although I wanted to be a full-time member of the GI division and have all the responsibilities of teaching and coverage and et cetera, and doing all the things everybody else did. I still wanted to have 3 sessions a week of outside private practice, so I maintained my, as they call it here, clinics. I maintained that outside of the institution, so I kept a private practice until the very end. So we just wrote it off if they couldn't afford it.
Do you think that practice has changed?
It's not because doctors would mind giving of their time freely, because we all do. And I think in my contact with the students today, I think the students are magnificent, and they all would certainly be willing to donate of their time, but they're not allowed to because of the structure of the institutions, and the structure of the institution of medicine, and the structure of the third-party payees.
How did you learn the business of medicine and how to run your own practice?
You never taught any of that, and I think there is some of that being taught today. And I know that when I was here in the GI division, I would spend some time toward the end of a person's fellowship helping them organize their setup for their office, what to buy, what kind of records to keep, and so forth. But none of that was ever taught. So you learned it by hook or crook. Nobody taught you what kind of records, what kind of financial records to keep, etc. So I learned it from the people around me, by the people that were my friends, and it was just, it was on, learning it on the road, so to speak.
How do you feel the cost of medical education today and when you were in school affects entering physicians, their choice of what careers to choose? Or
Well, the cost has changed drastically, and but then again, the dollar has been devalued drastically, so that the $25,000 income that I was talking about today is unheard of in gastroenterology circles or in medical circles. The cost of tuition when I started medical school, I believe, was $1,200 or $1,300 a year, and it finished. When I finished, it was about $2,400 a year, so it doubled in 4 years. And today at Harvard, it's about $35,000 a year. So does that influence people that go into medicine? I think people that are really dedicated to go, the answer is no. If they're not so sure, then maybe yes, because a lot of people do come out of these institutions with a heavy debt. But depending upon the institution, I was lucky enough to get a full scholarship, and I had to have a job. I mean, they required, if you get tuition assistance, you also had to work. But the job was, something that you could study at, covering a laboratory at night or whatever. And I think that the wealthier institutions still have large chunks of academic or financial assistance. I'm not too sure that it made that much difference. Back then, $2,400 a year was a lot. When you could buy a car for $600, $2,400 for tuition.
Do you think the debt load carried by students today influences what specialty they go into, or if they go in?
Well, I'm not so sure. I think that a lot of students may very well, because they have a debt load, go into specialties that will have a higher income. But then again, the students that I've seen over the last 5 years of PPS are an awfully dedicated bunch of kids, and I shouldn't call them kids, are young physicians to be, and they are really intent on going into primary care practice. Maybe that's one of the good things about this institution, and that is that it was predicated on and charged to develop primary care docs, and your tuition is lowered if you promise to stay, I think it's 2 years in the state of Massachusetts, and once you're here 2 years after your training, very often you'll stay on, and in large part this is primary care, namely family practice or internal medicine or pediatrics. So I think that there's a shift back from doing the super specialties into primary care medicine.
You mentioned before that when you first started practicing here, there were several hospitals in Worcester, and now obviously there's a lot of consolidation. Has that been a benefit to the practice of medicine for the physicians and the patients, or?
Well, I think that the answer to that is yes and no. Just last year there was a bill that was passed in the legislature that allowed postpartum mothers to stay in the hospital 2 days. Before that, they were delivered and then discharged very often the same day or within 24 hours. So I think that what happened was that many of the beds that were previously for OB were no longer necessary, so that many of the beds were changed to general medical beds. And similarly, this happened to many other cases. We're now doing, as in my own field, in gastroenterology, we're doing things that would previously require an exploratory laparotomy, for example, which would require people to be in the hospital for at least a week or 10 days or longer. Today, it's an outpatient procedure to remove polyps or to do other things that we do. So that made it mandatory to shrink the number of in-hospital beds. So by necessity, the hospitals no longer were needed to do some of the things that we were able to do outside of the hospital. think in terms of ophthalmology. People who had a cataract removed had to lie flat on their back for 10 days to 2 weeks. That was in hospital care. Today, they go in as an outpatient in the morning and they're home at 10 o'clock in the morning with an implant. So if they have a cataract removal. So that's drastically changed the need for in-hospital beds. And we could go down the list of all the different types of surgery. For example, I had a knee operation after my second year of medical school, and I was in the hospital for about a week or 10 days and on crutches for, I can't even remember how long. And it was open knee surgery. Today, arthroscopically, you're in and out, and you're out the same day, and walking within a week. So it's altogether different. The impact on your question was, it's good to be able to do many of these things as outpatient. It's safer. The procedures are quick. They're perfected. They're much better. A lot more can be done more rapidly. And there is no need for patients to be away from their home. Patients don't like to be in hospitals. They want to be at home in their own bed and listen to their own music or read their own newspapers. But in another sense, it's bad because somebody dictates to you how long you must keep your patient in the hospital. So if, for example, somebody, in the estimation of the physician, should be in the hospital for whatever reason, I mean, you could list them from A to Z, then they ought to be able to have a certain amount of determination as to how long the patient stays in.
Do you feel that a resident training in internal medicine now really only sees the sickest cases and doesn't understand as much as you did when you went through your residency?
Well, going back to the discussion we just had about how things have changed, back in my days of training, a person who came in with acute cholecystitis, for example, you made the diagnosis, you operated on the patients, or you treated them medically, and you could follow them. Today, that's not done, so the trainee today no longer can follow that patient, except for the fact that most of them are required to have a certain amount of training with docs that are in offices. I know that even in the PPS course, everybody had an LPP responsibility, and that each one of the students had to go to a doctor's office in an afternoon and saw what the everyday flow of patients was like. That's where you saw the sore throats and the achy joints and the upper respiratory infections and the urinary tract infections, and and they're being cared for in doctors' offices today, as they rightfully should be. If the training program doesn't allow for that, then I think there is something lacking in the training program. So that I think that the trainees today should and can get adequate exposure to the kinds of things that they're going to see on an everyday basis if they go into primary care physician. If they become a cardiac surgeon and they're going to do bypasses or valve replacements, they're not going to do that in an office, although the day may come when they'll do it through endoscopy or through a robot. Who knows?
How do you feel physicians are viewed today? Are they viewed any differently than when you first started practice?
I think there's still an element of awe about physicians, and there's a certain amount of respect. But I think that the population is much more informed now, that because of the mass media and the information they get, by the way, in large part some of that information is incorrect, but that's okay, they get it, and so they come to the physician with a lot of questions. Implicit in the questions is that they have some information, and that you better have that information yourself. I think that, so that in one respect, I think the physicians still have a good standing in community relations. In another respect, I think that a lot of physicians are looked upon as people that feel that they know everything and aren't to be questioned, and that's because perhaps they just don't have enough time to discuss matters with their patients. You can't really just spend 15 minutes, write out a prescription, or and let the patient go without a certain amount of discussion, a certain amount of allowance for questioning. And I think what's happened because of all of this is that the alternative forms of medical care have become very popular today, because patients are questioning why aren't we using more of the osteopathic or chiropractic or homeopathic or whatever kinds of hands-on kinds of medical care, alternative care. And more, I think practicing physicians are using those. And rightfully so, because we can't cure it all.
In talking to some other physicians, it seems like preventative medicine has been a concept that grew up and is now much more available in practice. Can you talk a little bit about how
Sure.
that has changed?
Oh, yes. I think that we never, of course, we didn't have things like mammography, and pap smears were just beginning back when I started practicing. And even immunization wasn't mandated the way it is today, and following up on immunization with every 10 years for a tetanus booster, and PSAs for men to check for prostate malignancy. And these things are all changing as time goes on, and they're being perfected, and it's marvelous. I mean, things are being picked up early. I'm afraid that what's happened, though, I'm all for the newer ways of preventative medicine, and it does pick up things earlier. But unfortunately, what's happened is that the lay press has talked so much about what's right for osteoporosis and what's your risk of breast malignancy, and how much exercise you must do and what exactly and precisely your weight must be, that patients are aware of all these things and are extremely frightened by it. So you see a lot of patients coming in saying, that they are concerned about all these entities that supposedly are prevented or picked up early. Why aren't you doing a PSA every year? Why aren't you doing a mammography every 3 months instead of every year? Why, just recently, sigmoidoscopy was through a Swedish, Finland, and third country was Norway, was found not to have the perfection that we previously thought it did in picking up malignancy of the large bowel, and that we always thought, here at least, that the colonoscopy was the gold standard, and that practically everybody should have a colonoscope. But there are two factors. Number one is that it is more expensive. Number two is that, and the third-party insurance, we're not going to pay for it. And number two is that patients don't like to have colonoscopies. I personally feel that you could probably train nurse practitioners to do colonoscopies rapidly and thoroughly, and the charges should be reduced to the level of a barium enema. And so you could have somebody do 4 colonoscopies per hour. They can be done in 15 minutes if some of our fellows were able to do them thoroughly in 15 minutes. And as you get more adept at doing it, you're able to do them rapidly. In most patients, sometimes it's more difficult. So that's a long-winded answer to your question, but preventative medicine is here to stay. It's a marvelous thing, but it shouldn't frighten patients.
Okay. Then, just to wrap up, would you encourage people to go into medicine? And for those doctors going into medicine, what advice would you have for them?
I think that something has to well up from the individual privately to make them want to go into medicine. It's a very difficult field. If anybody asks me what the primary prerequisite to going into medicine is, my answer is a strong pair of legs. It's physically a very difficult job. That just presumes that you're intelligent enough to get through medical school and college and medical school and training and so forth. I mean, everybody who's there will get through, but it's also physically challenging, as you'll get to know as you go through your clerkships and you're up all night, and this goes on throughout your life. You're awakened during the night by phone calls. You'll quickly learn how to go right back to sleep, or we in gastroenterology had to come in and do all the endoscopy, not do, but had to be with our fellows while they were doing endoscopies at night. So when you were on call, you practically almost every night had to come back into the hospital. So you came in and you went home and went right back to sleep. So physically it was very, very difficult. What would I advise them? I would advise them that it's a extraordinarily rewarding, magnificent field to be in. I would have never swapped it for anything else in my own personal life. I think that it was a marvelous way to spend a lifetime. I sound like it's over. It's not yet. But I think that, no, I would encourage people who want to go in. I would not take a person that is not interested at all and say this is the only field that you should go into. In my own family, we had 3 children. I never encouraged my children to go into medicine. No, none of them did. If they wanted to, they saw what medicine was like, and you know how much time one had to put in to be a physician. So I think it's something that comes from the individual.
Thank you very